I'd now like to introduce Dr. Samuel Chan, who is a kidney specialist and an NHMRC Emerging Leadership Fellow working at Metro South Health in Queensland. He is an enthusiastic clinician, scientist, teacher, and mentor, and has a PhD in transplant infectious diseases completed at the University of Queensland. Dr. Chan is interested in the design and implementation of clinical trials in collaboration with Australasian Kidney Trials Network to reduce gastrointestinal symptom burden and prevent urinary tract infections in chronic kidney transplant recipients. So I'd like to welcome Dr. Chan, who is going to present on gastrointestinal infections, including norovirus in renal transplant recipients. Thank you.
Thanks very much, Andrew. Good morning, everyone. Thank you very much, Adam, and many people for putting together this very important meeting. Transplant ID was my PhD topic, and I wanted to just share with you today some of the things that we've learnt over the years. The photo at the back here is the Princess Alexandra Hospital. It's the largest and the only transplant unit here in Queensland, and it's the largest one in Oceania. We're very lucky in this institution to have the Australasian Kidney Trials Network, AKTN, based at this centre, where we basically conduct all the clinical trials in kidney medicine in the one place, sort of a one-stop shop. Infections are important, and in terms of the how we manage infections, or how infections are looked at in kidney transplantation, there's been a group called SONG, the Standardised Outcomes in Nephrology group, which basically is a group of clinicians, a group of scientists who have worked together collaboratively across the world to come up with core outcomes that need to be mentioned, that need to be reported in clinical trials. And this has been established for the last decade. So in any clinical trial which is involving kidneys, that's my area, we need to report infections. There is so much heterogeneity in the reporting of infections in randomized clinical trials. You look at trials back in 2005, 2008, some of them won't report infections. But with this group here, which is worldwide, there are 6 or 7 parameters that must be reported in trials, and infection is one of those. The others include life participation, mortality, cancer, CVD, and graft health. So this is a big step forward for infection, and much of the work that I'm doing, looking at clinical trials, very much centres around this. So are infections important? I think they are important, and it's very important to firstly work out why they're important. So this was one of my initial studies of my PhD to define the burden of infections. And we used the Australasian and New Zealand dialysis and transplant registry to work out how important infections are. And what we found is in kidney transplant recipients who are matched for those who didn't have a transplant, the recipients are about 7 to 11 times higher of risk of dying from infections. And so this sort of provided the impetus for me, following my training in, RACP nephrology to build on this work. And I certainly acknowledge my colleagues who work with me, David Johnson and Carmel Hawley particularly, who've been the drivers behind, this body of work. The patterns of infections are changing, and what you can see over here is that the incidence of bacterial, virus, fungal infections, and so on are changing. We get a spike of fungal infections, in the last period, and this sort of follows on from what Peter was saying with the pneumocystis. We sort of had an outbreak at PA about 10 years ago. 10 or 12 years ago, and that probably may explain some of that data. Pulmonary infections, and by the way, this is data that's not just looking at incidence, this is looking at mortality, people actually dying from these infections. So pneumonias at the moment appear to be, the highest, followed by septicemia, CNS, and urinary tract infections. So this is sort of just an overview that infections are important. Infections kill. People are, for example, at 7 to 11 times higher risk of dying from infections compared with the general population. I'm going to share with you 3 studies that I did during my PhD, and then I'm going to talk a little bit about what I'm doing now as an NHMRC fellow in terms of trying to build the next body of work, incorporating clinical trials and what I've done, and hopefully attract some of you to work with us or bridge collaboration. One of the things that bothers us as physicians in the kidney medicine is people getting infections. And a lot of this is stemming from because people have a lot of gut symptoms. Early on in my training, I was told by my colleagues that you really need to find out from patients what they think are most important, and to try and gauge a view from consumers, our participants, our patients who we see day to day, what they think is most important. So one of the things I did was ask my patients at PA Hospital, the chronic kidney transplant recipients, what they viewed was most important with respect to their transplant. We gave them surveys, the Gastrointestinal Quality of Life Index, the Gastrointestinal Symptom Rating Scale, and the Structured Assessment Gastrointestinal Symptoms. And we found in this cohort of patients that most of our participants, about 88% of them, report gut symptoms such as indigestion and diarrhea. And about 45 to 40% of them report mild to moderate impairment in their quality of life. Those who are female, those who are using mycophenolate are associated with higher GI symptoms. So the reason for this study is, yes, infections are common. Yes, GI symptoms are common. What are we going to do about them? So I did it sort of a basic sciences approach in my subsequent study to explore the role of the gut microbiome and see whether there were any changes after transplantation which might explain why our patients get infections, why our patients have these gut symptoms, because gut symptoms and infections are very similar. So what I actually did in this study was look at living donor kidney transplant, okay, at our centre here in Queensland. So what happens here is I focus specifically on those who are having living donor transplants. So those participants will be staged. They will know when to come in for their surgery, but I'll also look at the gut microbiome of their donors. So often these could be people who are their relatives, so blood-related relatives, but sometimes they may not be their blood-related relatives. And so what they would do is they would provide us with a gut microbiome sample, a stool sample, a week before their surgery, and then give us another sample 8 weeks after surgery. And so we would do this to the kidney transplant recipients who are undergoing transplantation, who are undergoing surgery, who are having immunosuppressive therapy of tacrolimus, mycophenolate, prednisone. They'll have had, in some cases, thymoglobulins. If there's had rejection, they would have been on basilizumab, prior to all of this. So they would be fairly immunosuppressed. Compared with the donors, they're just offering their kidney. Shouldn't say just, but they are offering their kidney to their other half. And so we would examine the gut microbiome. We'll look at the Shannon diversity. And so basically, this was just done during the COVID era, like right at the peak. And we were really, really grateful for these participants to come forward and participate when our unit basically shut down its transplant service because of what was happening in the country. But we were aiming for 15 donors, matched to 15 recipients, but eventually we got to 12 donors matched to 12 recipients. And on this slide here, it highlights, the characteristics of our participants. All our patients get tacrolimus, mycophenolate, prednisone in this cohort, and I've highlighted the CMV status of those donors and recipients. Antimicrobial use was important. And so the reason we needed to collect this data and look at this data is because we really were bothered by two things in our unit: urinary tract infections and GI infections. And norovirus really bothered many of us. We just didn't know why our patients were getting norovirus, a couple of months after. And urinary tract infections or recurrent urinary tract infections and resistant urinary tract infections were very high. So we wanted to really look at what was going on. But it is a small sample, and unfortunately I can't really tell you very much, but hopefully future studies, which I'll allude to later on, may show that. Now, this is looking at the transplant recipients. So these are people who've had their transplant, they've undergone surgery, they've had anaesthetic, they've been immunosuppressed with what I've alluded to. And you can clearly see that the richness, the gut microbiome richness at baseline is even worse, after transplantation. So my patients or our patients in kidney medicine, they're on dialysis. Some of them are on dialysis. So their gut microbiome is already pretty weak. Their Shannon diversity index is quite low. Their richness is quite low. So undergoing a transplant with all these immunosuppression, even worsens it. Now, compared with the donors, there was no change. So we would not be doing a nephrectomy on someone with comorbid illness. So our patients who were donors, their richness, their diversity was unchanged after a nephrectomy. So what we can conclude, from this is transplantation affects our microbiome. Could the changes in the gut microbiome explain why our patients have infections? Could it explain why our patients have GI symptoms? That's our hypothesis. So the final, in terms of what before I move on to my next study, in terms of what we found, UTIs were quite high. 4 out of 12 participants got UTIs. So this is within 2 months of having a transplant. That really bothers us, and living donor kidney transplants, they're not meant to be, high risk, compared with deceased donor kidney transplants where there are many more factors at play. CMV would be far too early. BK virus, we saw 2. Interestingly, we didn't have anyone with gastroenteritis, but it might be too early, really, within 2 months to see. We saw herpes simplex, a few cases of pneumonia, and hematological problems, neutropenia, which is a big problem, and something that we're looking into in our unit as well. So this was just a snapshot. We couldn't really make any inferences on whether these infections were associated, but hopefully we will be able to with my current grant. So what I then did, in my next story for my PhD was try and do a trial to try and do something that mitigates or that changes what is happening in the gut microbiome. So done at the PA hospital, it's a single centre study, so it does have its limitations. We looked at patients who were going for a kidney transplant acutely. So it's a big thing for our patients. They get caught up in the middle of the night, and they come into the hospital, and they have a transplant within hours, or within less than a day. And we would ask them kindly to come and be enrolled in this trial. And so this happened between October 2020 to May 2021. And what we aimed to do here was to enroll patients into 2 different arms, stratified by age and sex. We would give them a prebiotic supplement. This was in the form of green banana resistant starch, and placebo, which was waxy maize. This is in the formulation of a powder. You would take 1 scoop twice a day, morning and evening, often with your cereal. And what we would envisage to do would be look at these participants over 8 weeks. The reason is our patients often stay here for 8 weeks at PA. So they come in on their first day to have a transplant, they stay on the ward for about a week, and then they get discharged, and they usually have outpatient follow-up every day for a few weeks, and then, a few times a week, in the second half of the 8 weeks. So we were able to capture these patients, give them either the prebiotic or the placebo. And what we would do is assess their adherence, their tolerability, look at their stool samples. So we'll also undertake gut microbiome analysis to see whether there's any improvement, look at their quality of life and see whether there's any improvement in infections. This was a big learning tool for our unit, a big learning tool for me particularly, because this was my first clinical trial to be conducted during my PhD within a very, very difficult COVID period. And so there were lots of things I'm happy to share with you in terms of what I learned and what I would do differently when I do my next clinical trial for my grant. So this is a busy slide, so I've cut it down. So essentially, we were able to have about 86 kidney transplants performed during that 6 to 8 month period. A few people, 14 people, were not able to participate, and 72 met the eligibility criteria, and 60 provided consent. So about 12 people declined to participate in our study, and most of it was because they were too busy. They've had a kidney transplant, it's acute. The last thing they really want to do is enter in a clinical trial when there's so much going on. And 60 participants provided consent, which was our goal of 60 participants in 6 months. And unfortunately, we could only randomise 56 because 4 were not randomised. After providing consent, a few days later, they decided not to participate because they had rejection or, problems with, they were scared they were going to get adverse effects, which is absolutely fine. But it's again a learning tool that, it's not exactly what, trials are not exactly going to be planned in exactly the same way that you want them to be. Patients are patients, and we have to really work with them. So in the end, 56 people were randomised, 27 got the prebiotic arm. So that's the green banana resistant starch. Just to give you a bit of an overview about that. So why we chose a prebiotic is because it's not degraded or metabolized when you in the small intestines, unlike a probiotic. And so it goes down into your large intestines. And the implication behind this is that it releases short chain fatty acids, which is actually really good for the gut microbiota. It's meant to replenish it. Believe you me, I thought it was a load of, until I did this. And I told David, in Carmel, I said, this is just like, I just said, this is just not going to work. There's still going to be infection rates. Gut symptoms are never going to improve. And so this was sort of towards the exciting part, when finally, after months and months of headaches, consenting patients, following up with them. And thanks to all the great research nurses in our department and AKTN, of course, we were able to get to this stage where they were allocated the prebiotic. But then there were these discontinuations. Oh, goodness me. I was scratching my head. Why were they being discontinued? And there was this myth that because it had banana in it, it was promoting hyperkalemia. And our patients, they've had a transplant, hyperkalemia meaning hyperpotassium, but they've had a transplant, and I was getting, the cold shoulder from some of my colleagues because right after their transplant, some of their kidneys were not working, and yet they were having hyperkalemia. We shouldn't be giving them Resonium. They were going back on dialysis. And so we felt, because this was all blinded, of course, we felt, oh, this discontinuation group was all because of the hyperkalemia. Patients were just coming off it because they thought, oh, it's promoting hyperkalemia. I don't want it. Patients were blinded, of course. But then it was really, really funny that when we, unblinded it and at the end and realized that the discontinuation was actually very similar on both arms, on both the placebo and the prebiotic arm. And then, so at the end, we did it through intention to treat and, looked at the feasibility outcomes and the secondary outcomes. And so this is sort of a little bit about like the baseline characteristics, and it's very, very similar between the two. GN's probably the most common reason for our cohort at that time to have their transplants, followed by diabetic kidney disease, genetic kidney disease. Most of our participants were having their first graft, and most of them were Caucasian. So we were lucky to transplant some Indigenous patients as well. Now, this is the results slide. So we were able to achieve our target of recruiting 60 participants, although only 56 were randomized. There was only moderate adherence, or mild to moderate adherence, and mild to moderate tolerability. But there was an improvement in their gut symptoms. Okay, there was an improvement in their gut symptoms by in the intervention group compared with the placebo group. In terms of infections, which is the clinical outcome, unfortunately, we didn't really get to see an improvement in infections. 9 out of 27 participants reported infections in the intervention group compared with 10 out of 29. But in terms of looking at the gut microbiome, things did improve as a consequence of the intervention. So this is the green banana resistant starch. This is looking at the richness, and this is looking at the Shannon diversity. And this is the participants on green banana resistant starch at baseline. That is before they commenced the supplement. So our patients were not able to provide us with a stool sample before their surgery. It was about day 1 to day 4 after their surgery. And it's because it's virtually logistically impossible to ask a patient to poo on the day of their transplant. And I've got a PhD student who's trying to do something similar, and he's not doing kidney medicine, but I tell him it's virtually impossible to request a patient to poo on demand, because there is so many other factors, taking place at that time. But despite this, there was an improvement, a significant improvement in richness in patients who had the green banana resistant starch compared with placebo. And this was also very similar to that of the Shannon Diversity Index. So what our group concluded was that there is an improvement in the gut microbiota as a consequence of nutritional therapy. But there wasn't any improvement in infection outcomes. And we suspect that the reason there isn't any improvement in infection outcomes was it was only there for 8 weeks. It was too short. And most of the infections that we often see in our patients, are much longer, down the track, usually 12 months or more. So where to from here? In terms of my NHMRC grant, the 2 things that I'm actually focusing on in our group, in AKTN at the PA hospital, is looking at 2 big ticket items, which I'd love for anyone in the audience to tell me whether we're doing the right thing or not. Looking at urinary tract infections in kidney transplant recipients. We did a survey, part of my PhD, I didn't report it here, but that basically reported how important consumers, so patients, their caregivers, as well as healthcare professionals such as us, view about UTIs. And what we want to do is to establish a clinical trial that sort of prevents it. And we've been invited to put together, so this is sort of like the clinical trial sort of the end game. But we've been invited to do a Cochrane review to explore interventions to prevent UTIs, and that's sort of up and running. Looking at the role of D-mannose, looking at the role of vaginal estrogen therapy, looking at the role of prebiotics, probiotics, symbiotics. So this is not treatment, this is prevention. And the reason we want to focus on prevention is we want to reduce hospitalizations. We want to reduce hospital costs, which is essentially the main gain for policy advisors and people in government. And so that's sort of the first body of work. And then the second thing that we've sort of got to, and Adam and a few other people and many of the infectious disease physicians here in Brisbane have helped, is to, we've put together a consumer engagement survey where we ask you guys, what are the important things that we would do if we were to set up a clinical trial to prevent UTIs in transplant recipients? And we're going to publish this. And the results of that survey say that people want kidney transplant recipients to be high risk, to be prevalent, and to consider the use of vaginal estrogen therapy as a preventative mode, antibiotics, and one of the nutritional therapies. And this is similar to what you were saying. We were thinking of doing an adaptive arm, an adaptive clinical trial with some of the other centres here in Australia. And the other part that we're going to continue to focus on is reducing GI symptom burden. Well, that's it from me. Thanks very much, and I'm happy to take on any questions.